The fifth chapter of ATLS, that is abdominal and pelvic trauma. Okay, so the assessment of circulation during the primary survey include early evaluation for possible intra-abdominal and or pelvic hemorrhage. So assessment of circulation during ABCD, it will also evaluate the intra-abdominal or pelvic hemorrhage. Okay, so penetrating wound between the nipple and perineum may cause intraperitoneal injury. Okay, so remember this landmark, nipple to perineum. Okay. The significant blood loss can be present in the abdominal cavity without a dramatic change in external appearance or dimension of the abdomen, without obvious sign of peritoneal irritation. So they are saying that there is a significant blood loss in the patient of abdominal injury, but you may not get any change in abdominal appearance or dimension. Okay, and even you will not get the obvious sign of peritoneal irritation. Okay. So now they are telling the anatomy of abdomen. So few important day-to-day word which we may ignore, but we should know the exact landmark, like anterior abdomen. So what is anterior abdomen? So superiorly costal margin and inguinal ligament and pubic symphysis inferiorly. Okay, and area between anterior axillary line. Okay, so anterior axillary line and above the this what you call this costal margin and inguinal ligament inferiorly. Okay, if I make a small rough diagram here, so this is the costal margin, anterior axillary line, inguinal ligament and pubic symphysis. Okay, so this is the anterior abdominal wall. Okay, now come to the thoracoabdomen. Okay, so thoracoabdomen is the below the nipple line. Okay, below the nipple line, and then infrascapular line posteriorly and superior to costal margin. Okay, so in abdomen we have taken the upper margin of costal. Okay, costal margin. So in thoracoabdomen, the superior to costal margin. Okay, this superior to costal margin and above the nipple, anteriorly the nipple line and posteriorly the infrascapular line. Okay, so this area comprises of thoracoabdomen. Okay. Now, so diaphragm raised at the level of fourth intercostal space. So this is one liner. So you can remember D for fourth. Okay, D is fourth letter, no? So it's a fourth intercostal space. Okay. Then fracture of the lower rib and penetrating wound below the nipple line can injure the abdominal viscera. This we have already seen. Okay. What is flank? So area between the anterior posterior axillary line and from sixth intercostal space to the iliac crest. Okay, so remember the area between the anterior and posterior axillary line, side to side we have got the landmark, and from the above sixth intercostal space and iliac crest, below the iliac crest, above the sixth intercostal space. Okay. So this flank is okay, sixth letter, no? So sixth intercostal space you can remember. Then back is posterior to posterior axillary line and from tip of scapula to iliac crest. Okay, so anteriorly what is abdomen? Anterior abdominal wall, behind it is back. Okay, that corresponding area is back. So tip of the scapula above and below is the iliac crest. Okay, and the flank and back contains the retroperitoneal space. Okay. So abdominal wall. So what are the important structure in retroperitoneal space? They ask. So abdominal aorta, inferior vena cava, duodenum, pancreas, kidney, ureter, and ascending and descending colon. Okay, not transverse colon. Okay, so aorta, IVC, duodenum, pancreas, kidney, ureter, ascending and descending colon are part of retroperitoneal organ. Okay, so injury to the retroperitoneal visceral structure are difficult to recognize. Okay, because they are deeply seated. Okay, and may not present the peritonitis early. Okay, so what is pelvic cavity? So pelvic cavity area surrounded by the pelvic bone. Okay, and the lower part of the retroperitoneum and intraperitoneal space present in peritoneal cavity. Okay, and it contains the rectum. Okay, bladder, iliac vessel, and female internal reproductive organ. Okay, so now the blunt injury, types of mechanism of injury. So blunt injury, so searing injury, it's a form of crush injury. Okay, so they will ask. Okay, so deceleration injury. Okay, so differential movement of fixed and mobile part of the body produce this kind of injury. So like example like liver and spleen laceration, bucket handle injury of the small bowel, also example of deceleration injury. Okay, now come to the blunt trauma. So what is the most common injured organ, solid organ in blunt trauma is the spleen. So blunt trauma organ most frequently injured is spleen. 1,000 times asked this question. Okay, blunt trauma most common injury is, most common organ injured is spleen. Next is liver and small bowel, but you have to remember this is spleen. Okay, so airbag deployment does not preclude abdominal injury. So airbag does not prevent the abdominal injury. Okay, now come to the penetrating injury. So stab wound and slow energy gunshot wound causes tissue damage by laceration and tearing, but high energy gunshot wound causes the temporary cavitation. Okay, this ask. So which type of injury causes temporary cavitation? It's high energy. Okay, remember that. Now come to the stab wound. So most common organ injured in stab wound is liver. Okay, liver. Okay, or other way you can say in penetrating injury, most common organ injured is liver. Okay, others are small bowel, diaphragm, and colon. Remember, spleen is not mentioned in stab wound. Okay, so liver, small bowel, diaphragm, and colon. Okay, gunshot wound. Gunshot wound mostly cause the small bowel. Okay, others are colon, liver, abdominal vascular structure, but most common injured organ is small bowel. Okay, remember. Now come to the blast. So blast is combine of blunt injury and penetrating injury. Okay, so combine penetrating and blunt mechanism. Okay, so other specific organ injured in blast are tympanic membrane, lungs, and bowel. So air containing organ. Okay, because of blast over pressure. Okay, and clinician should not distract the by the blast injury. You have to follow the normal systemic approach like ABCD approach. Okay, okay. Now come we will see the some specific injury and associated organ injured. Okay, injury associated with restraint device. Okay, like lap seat belt. Okay, it can cause compression and hyperflexion. Okay, so that there is a bucket handle injury in which mesentery is injured. There is a rupture of small bowel and colon. Remember, colon also can injured in lap seat belt injury. Okay, then thrombosis of iliac artery and abdominal aorta. Okay, then chance fracture of lumbar vertebra. This is very important, many times asked. So chance fracture of lumbar vertebra. Okay, and then pancreatic and duodenal injury. Okay, this is also many times asked. Okay, okay. Now come to shoulder harshness. Okay, so submarining. Okay, submarining associated with shoulder harshness. Okay, now come to the airbag. In airbag that can cause contact deacceleration, flexion, hyperextension, but you can also remember the face and eye abrasion, mainly cardiac injury and spine fracture can be there in airbag injury. Okay. So this is stab wound. Stab wound, most common organ injured is liver, small bowel, diaphragm and colon. Okay. So combine this, I have explained. So in history there is one important point, like distance of assailant from the victim is important in shotgun. So if the distance is more than 10 foot or 3 meters, there is a less chance of major visceral injury in gunshot injury. So remember, 10 foot or 3 meter. Okay. Now come to the, so bowel sound does not necessarily correlate with the injury. Okay, remember, it's a one negative point, not. Okay. So if the patient present with rebound tenderness, like you are getting the rebound tenderness, do not seek additional evidence for irritation. Okay. Involuntary muscle guarding is a reliable sign of peritoneal irritation. Remember, it's a reliable sign. Now come to the pelvic assessment. So unexplained hypotension may be only initial indication of major pelvic disruption. So unexplained hypotension. Remember, it's unexplained. Means patient is present with hypotension but you are not getting the cause. So there may be pelvic disruption. Okay. And other sign you may get scrotal hematoma, blood at urethral meatus, and discrepancy in limb length or rotational deformity of leg without obvious fracture. So they may hint regarding pelvic disruption. So in this case you avoid manually manipulating the pelvis. Okay. You can do just gentle palpation of bony pelvis for tenderness. Okay. Gentle palpation of bony pelvis you can do. So if there is unstable hemipelvis, the migrate what cephalated because of muscular force and rotate outward because of gravity. So they may ask, in unstable hemipelvis, what is the direction of migration? So cephalated and outward. Okay. So and the binder, that pelvic binder should be applied over greater trochanter. This is 1000 times asked. So pelvic binder should be applied at level of greater trochanter. Okay, GT. Now come to the rectal examination. During rectal examination, you should assess for sphincter tone and rectal mucosa integrity or any gross bleeding. Okay. So do not place urinary catheter in patient with perineal hematoma or blood at the tip urethral meatus. Okay. So usually they say do not place catheter if the blood at the urethral meatus. But here one more thing, when in perineal hematoma you should not place urinary catheter. Okay, before definitive assessment of urethral injury. Okay. Now what is gluteal region? So iliac crest to gluteal fold known as gluteal region. So any penetrating injury to this area can cause 50% of incidence of intra-abdominal injury. Okay, 50%. Okay. So adjunct of physical examination like inserting gastric and urinary catheter can be part of primary survey. They can ask. So urinary catheter and gastric tubing done under primary survey only. Okay. So regarding gastric tube, if you find the blood in gastric content, suggest injury of esophagus or upper GI tract if nasopharyngeal or oropharyngeal sources are excluded. Okay. So severe facial fracture or possible basilar skull fracture, you should not insert nasogastric tube. Okay. Or if you want to insert, you should insert via orogastric. Okay. Gastric tube through mouth, not through nose, in case of basilar skull fracture or severe facial fracture. Okay. So if you are planning to do fast, better to do catheterization once the fast has been done, because the full bladder enhance the pelvic image. Okay. So you should delay the catheterization till fast obtained. Okay. So absence of hematuria does not exclude any injury to genitourinary tract. Okay. If there is no hematuria, it doesn't mean there is no genitourinary tract injury. Okay. So in this case, you should do retrograde ureterogram. Okay. So retrograde ureterogram is indicated when patient is unable to void pelvic binder. If patient has required pelvic binder, blood at the meatus and scrotal hematoma or perineal ecchymosis. In these cases, you should do retrograde ureterogram. Unable to void, patient has required pelvic binder, blood at meatus, scrotal hematoma or perineal ecchymosis. Okay. So the same line, avoid nasogastric tube in mid-face injury, use orogastric tube. Okay. So pediatric patient has high rate of acute gastric distension following trauma. So gastric tube should be given, and what is the benefit of gastric tube? So it reduces the risk of aspiration and vagal stimulation. This vagal stimulation also important. So gastric tube reduce the risk of aspiration and vagal stimulation. Okay. Now come to the finding required for abdominal evaluation. If any injury patient you are getting all this finding, you should rule out you should do abdominal evaluation. So what are the finding? Altered sensorium, altered sensation, injury or adjacent structures such as lower limb, pelvis or lumbar spine. Remember this lumbar spine. Okay. Then equivocal physical examination. Okay. And prolonged loss of contact with the patient, like patient is going for GA or any lengthy radiological studies. Okay. Or seat belt sign present with suspicion of bowel injury. Okay. In this all case, you should do abdominal evaluation. Okay. So now come to the how you are going to evaluate. So X-ray for abdominal trauma. So you should take AP chest X-ray. Okay. The chest should come in abdominal X-ray. Okay. The chest part. Okay. So radiopaque marker or clip applied to all entrance or exit wound. Okay. If there is entrance and exit wound, you should apply the radiopaque marker, so you can appreciate the distance of foreign body from the body surface. Okay. And in this case, you should take two views, AP and lateral. So spatial orientation of foreign body should be ascertained. Okay. Okay. Now this is important table, comparison of diagnostic peritoneal lavage, fast and CT scan. Okay. So advantage of diagnostic peritoneal lavage. Okay. So it is early operative determination can be done because it performs rapidly. You can detect bowel injury and no need to transport from resuscitation area. So from emergency only you can do diagnostic peritoneal lavage. Okay. So what are the disadvantage of diagnostic peritoneal lavage? It is invasive and there is a procedure related injury because of invasive nature. Okay. Now patient required gastric or urinary decompression before doing DPL for prevention of complication. Okay. And you cannot repeat, you cannot do again and again diagnostic peritoneal lavage. Okay. Major disadvantage. And there is a interference of interpretation of subsequent CT or fast because it's an invasive test. Okay. Okay. And this is low specificity. Okay. And there is you cannot diagnose diaphragmatic injury. So an indication, abnormal hemodynamics in blunt trauma patient or penetrating abdominal trauma without other indication of laparotomy. Okay. So if there is a penetrating trauma and there is no indication of laparotomy, like you cannot decide this patient need laparotomy, so you should go for DPL. Okay. Okay. Now come to the fast. Fast is also early operative determinants. Okay. And this is non-invasive and perform rapidly. Okay. And you can do again and again. So repeatable. It's a repeatable. And this is also no need to transport from resuscitation area. So you can do resuscitation and fast simultaneously. Okay. but disadvantage are it's a operator dependent disadvantage. Okay, operator dependent, and bowel gas and subcutaneous air distort the image. You can miss the diaphragm, bowel and pancreatic injury. Okay, not completely assess the retroperitoneal structure. Okay, it cannot assess the deep structure and does not visualize the extraluminal air. Okay, and body habitus can limit the image clarity. So in obese patient it is difficult to assess the injury. Okay, okay, and the indication are same as diagnostic peritoneal lavage. Okay, okay. Now come to the CT scan. So this is anatomic diagnosis. This is also non-invasive. You can also repeat CT scan. Okay, and it can visualize retroperitoneal structure. Important. Okay, and you can also visualize bony and soft tissue structure. Okay, and visualize extraluminal air also. This is important. Extraluminal air. Okay, so but the CT scan has got higher cost and longer time, and this is also associated with radiation and IV contrast exposure, and you can also miss diaphragm injury. So diaphragm injury you can miss by all three: DPL, FAST and CT scan. Okay, we'll tell which investigation can diagnose diaphragm injury. Okay, very soon. So it can also miss some bowel or pancreatic injury. Okay, and it required transport from resuscitation area. So this is differentiating feature from both two. So DPL and FAST can be done with resuscitation, but CT scan you have to take out the patient from resuscitation area. Okay, an indication if normal hemodynamics in blunt or penetrating abdominal trauma. So remember, DPL and FAST can indication is abnormal hemodynamics, but CT scan has to be done in normal hemodynamics in blunt trauma or penetrating trauma. So normal hemodynamics is important. Okay, or in penetrating back and flank trauma without other indication of laparotomy. Okay, so few important points regarding FAST. Okay, so it can also detect the pericardial tamponade. So pericardial tamponade is one of the non-hypovolemic causes of hypotension. Okay, there is no loss of blood, still patient is hypotensive in pericardial tamponade. Okay, so this you can diagnose with the FAST. Okay, okay. So in FAST you have to examine the four important regions. So one is pericardial sac, other is hepatorenal fossa, then is splenorenal and pelvis. Okay, pelvis or pouch of Douglas. So important: heart, liver, kidney, spleen and pelvis. Okay, okay. So false negative FAST can be present in obese patient, and FAST is insensitive for diagnosis of hollow viscous injury. Important. Okay, okay. Now come to the diagnostic peritoneal lavage or DPL. Okay, so this is FAST being done. This is the probe position in the FAST, and this is the FAST image of right upper quadrant showing liver, kidney and free fluid. Okay, free fluid. So this in image based you may get this picture. Okay, so we were talking about the DPL. So this picture is showing DPL. Okay, diagnostic peritoneal lavage. Okay, so it is here it is again hemodynamic normal patient where FAST and CT is not available. So DPL is old age procedure. Okay, it's not commonly used nowadays. Okay, rarely used because it's invasive and required surgical expertise. Okay, not everyone can do DPL. Okay, so relative contraindication of DPL are previous abdominal operation, morbid obesity, advanced cirrhosis and pre-existing coagulopathy. So these are the relative contraindication of DPL. Okay, so it can be done through open, semi-open or closed or Seldinger infraumbilical technique. So most commonly done infraumbilical. Okay, most commonly done infraumbilical. Okay, but supraumbilical also done in which all cases? When there is a pelvic fracture. Okay, and when there is a advanced pregnancy. Okay, okay, okay. Aspiration of gastrointestinal content if you are doing DPL and you are finding the GI content, vegetable and bile and more than 10 cc of the blood in hemodynamic abnormal patient, you directly go for laparotomy. Okay, 10 cc is important. Now come to the CT. So CT is time consuming procedure, and you should not perform CT when you are planning to refer the patient at higher level, because it will delay the transfer. Okay. So what are the relative contraindication of using CT? So if patient is uncooperative and allergy to contrast, you should not do CT. Okay. So in case of absent is hepatic and splenic injury and there is a presence of free fluid, you can this can suggest the injury of GI tract or its mesentery. Okay. So it is indication of early operative intervention. Okay. Now come to the diagnostic laparoscopy or thoracoscopy. So it is done in hemodynamically normal or penetrating trauma patient without indication of laparotomy. So if any injury patient, there is no indication of laparotomy, patient is hemodynamic normal and penetrating trauma is present, so you should do diagnostic laparoscopy or thoracoscopy. So diaphragmatic injury and peritoneal penetration can be assessed. So remember, diaphragmatic injury assessed through diagnostic laparoscopy, important. Now few contrast study like urethrophy, cystography, IV pyelogram and GI contrast study. So urethrophy. So before inserting urinary catheter, okay, you should do, when you are suspecting urethral injury, so before inserting urinary catheter you should do urethrophy. How you will do? You should insert 8 French urinary catheter, 8 French, okay, and balloon inflation with 2 ml of 2 ml only, okay, only 2 ml, and through this catheter you should instill 30 to 35 ml of undiluted contrast material, undiluted, okay, and radiograph is taken with AP projection, and in this stretching of the penis towards any of the patient's shoulder. Okay. So this is urethrophy. Now come to the cystogram or CT cystography. So this is most effective method diagnose intraperitoneal or extraperitoneal bladder rupture. So any patient present with suspected intra or extraperitoneal bladder rupture, you should do cystogram. Remember this cysto means bladder only. Okay. So in this position, that catheter should be held, that syringe barrel, okay, syringe barrel held 40 centimeter above the patient, and you should instill 350 ml of water soluble contrast. Okay, here it was 35, here it is 350. So urethra 35, bladder 10 times more, that is 35, 350 ml. Okay, and additional 50 ml of contrast instilled to ensure bladder distension. Okay, and AP picture taken in 3 phase: pre-drainage, field and post-drainage. Okay. If CT is not available, okay, you should also do IV pyelogram, IVP. Okay. So in this, high dose and rapid injection of renal contrast, that is screening IVP. Okay. So high dose and rapid injection. Okay. So 200 ml of iodine per kg body weight is given, and it will visualize the renal calyces. Okay. So abdominal radiograph should appear 2 minutes after injection is completed. So first you instill 200 mg per kg of iodine contrast, and after 2 minutes, 200 and 2 minutes, okay, you should take the radiograph. Okay, and if there is no visualization, may warrant further radiological evaluation. Okay. Few more pages. So what is double and triple contrast? When you given per oral and IV contrast, it is double oral, and when along with this you should also given rectal contrast, it is triple contrast. Okay, triple contrast. So it is useful in flank and back injury. Okay. So most of the abdominal gunshot wound are managed through exploratory laparotomy. Okay. So indication of laparotomy in patient with penetrating abdominal wound are hemodynamic unstable, anything hemodynamic unstable, you should go for laparotomy. Then transperitoneal trajectory, if any trajectory has crossed the peritoneum, okay, and there is a peritoneal irritation, any sign of peritoneal irritation or sign of peritoneal penetration like evisceration, okay. So these are the indication of laparotomy in penetrating injury, okay. Few more points. So, and there is one line, DPL may not detect retroperitoneal colon injury, okay. So indication of laparotomy, okay. In blunt trauma abdomen, blunt abdominal trauma with hypotension with positive fast, okay, or intraperitoneal bleeding, okay. So you should go for laparotomy. Now next is hypotension with abdominal wound penetrate the anterior fascia. If the abdominal wound penetrate the anterior fascia, you should go for, and it has present with hypotension, go for laparotomy. Then gunshot wound that traverse the peritoneal cavity, already explained. Evisceration, multiple times asked. Evisceration is indication of laparotomy, okay. Then bleeding from stomach, rectum or genitourinary tract following penetrating trauma, okay. If any bleeding from stomach, rectum or genitourinary tract, okay. Then peritonitis, okay, this is important indication. Then any free fluid present retroperitoneal space or rupture of hemidiaphragm, okay. And the last one is CT scan, contrast CT demonstrate rupture GI tract, intraperitoneal bladder injury, renal pedicle injury and severe visceral parenchymal injury. You should also go for laparotomy, okay. And one more indication, blunt or penetrating abdominal trauma, and as in aspiration you are getting GI content, bile, vegetable fluid, okay. The same thing I explained, the 10 cc or more blood in hemodynamic abnormal patient, you should go for laparotomy, okay. Now come to the specific injury like diaphragm injury. So diaphragm injury is more common on the left side, remember, diaphragm left side, okay, because on the left side diaphragm is on lower, so high chance of injury, okay, remember. Then chest x-ray, in what you are getting in chest x-ray in patient with diaphragmatic injury, elevation or blurring of hemidiaphragm, okay. So duodenal injury, in duodenal injury the patient may give history of bicycle handlebar, or on aspiration you are getting bloody gastric aspirate or retroperitoneal air, since duodenal means retroperitoneal structure, okay. Now come to the pancreatic injury. So early normal serum amylase does not exclude major pancreatic trauma, okay. So amylase level can be elevated from other pancreatic sources, okay. That's why it's not that much reliable, okay. And in this case you should do double contrast CT, okay. May not identify the significant pancreatic trauma, immediate post-operative period up to 8 hours. So CT scan up to 8 hours could not identify the major pancreatic trauma, okay. Up to 8 hours, important time, okay. Now come to the GI, genitourinary injury, okay. So gross hematuria is indication for imaging of urinary tract, okay. So abdominal CT scan, in this case you should do abdominal CT scan with IV contrast, okay. So thrombosis of the renal artery and disruption of renal pedicle, patient may present without hematuria, okay. Thrombosis of the renal artery or disruption of renal pedicle, okay. Now come to the hollow viscous injury. If you are getting seat belt sign, that is transverse linear ecchymosis over the abdominal wall, or chance fracture, that is lumbar distraction fracture, in this case there is a high chance of hollow viscous injury, okay. Now come to the other solid organ injury. If you are getting isolated solid organ injury, there is a less than 5% chance of concomitant hollow viscous injury, okay. Then pelvic fracture, important, okay. So in the mechanism of pelvic fracture can be AP compression, anterior-posterior compression, lateral compression and vertical displacement of sacroiliac joint, okay. So in AP compression there is a external rotation, important, and the tearing of posterior venous plexus, okay. In lateral compression most common mechanism of pelvic fracture in motor vehicle accident. Okay, so lateral compression, and there is a internal rotation. Okay, in this internal rotation, and there is a injury of bladder and urethra. Okay, so in frail and elderly patient, high chance of bleed. Okay, and vertical displacement of sacroiliac joint disrupt the iliac vasculature. So there is a picture based on this. This is AP anteroposterior compression of pelvis leads to open book fracture. Okay, open book, asked many times, open book fracture, AP fracture. Then lateral compression. Okay, so this is closed, and this is most common, 60 to 70%, and this is vertical shear. Okay, okay. So major pelvic instability present if the patient fall from height greater than 12 feet, commonly result in vertical shear injury. Okay, so any patient give history of fall from height more than 12 feet, high chance of vertical shear injury. Okay, okay. And hemorrhage is major potentially reversible factor contributing to mortality in pelvic fracture. Okay, okay. So now is management. Okay, so they are just showing X-ray before pelvic binder, X-ray after pelvic binder. Okay, so this is the pelvic binder picture applying at the level of greater trochanter. Okay, okay. So the first thing is angiographic embolization if the facility is available. If not, then pre-peritoneal packing done. Okay, okay. And this is the flow chart of pelvic fracture and hemorrhage shock management. Okay, so surgical consultation, if surgical consultation and application of pelvic wrap or binder, if there is intraperitoneal blood, you should go for laparotomy. If there is no intraperitoneal blood, okay, you should apply pre-peritoneal packing or angiography and hemorrhage control and fixation device. Okay, so thank you. This was the 5th chapter of ATLS. Okay, lots of important point. Okay, keep studying. Thank you.